Hello, friends. Today I've come with such a topic which is so common in India, and I wonder how I missed this topic in last 100 lectures. So many PGs requested, sir, please give a talk on anemia. Yes, anemia is very, very important case, both in the exam as well as in day-to-day life. I have seen that many students fumbling to answer such a simple case of anemia. And this case will definitely be there in the exams because it's very common in India. And also, all sorts of questions will be asked in this particular case. Like in when we were undergraduates in medicine, they used to say respiratory case is a graveyard for the students in exams. Similarly, anemia can be a tough case in the exams. It looks so simple and easy case, but it can be a very difficult case. So I'm sorry, all these days I didn't take this class thinking that it's there anyway, but there was a request from so many students, so I'm taking this case today. What is the importance of anemia, knowing anemia in pregnancy? As I said earlier, it is responsible for about 20% of maternal deaths in India, and it must be more now. The incidence is in tropics 40 to 80%. Look at that. Any disease which is more than 10% is important. Now it is 40 to 80% in tropics. In developed countries also, it is 10 to 20%. So anemia does not differentiate between developed countries and underdeveloped countries. So even if the person is rich, she could still be anemic because of wrong diet and other things, which you will shortly come to know. In India, iron deficiency anemia is about almost 58.7%. It is an old estimate of 2016. The recent estimates must be almost similar. Though India is taking a lot of action for Anemia Mukt Bharat. As far as WHO is concerned, IDA is 42%. So this slide tells you about the importance of knowing everything about anemia. What's the definition? Of course, there is always a qualitative definition and a quantitative definition. What I mean by qualitative definition is that what actually is the problem. Quantitative is how to define it in terms of numbers. For example, postpartum hemorrhage. The quantitative definition is any bleeding more than 500 after a normal delivery is quantitative. But qualitative definition, even as less as 200 or 300 ml of blood loss, that will push her into shock. That is qualitative definition. So as far as qualitative definition is concerned, anemia is nothing but decreased oxygen carrying capacity of the blood. Simple. Decreased oxygen carrying capacity of the blood due to decrease in amounts of RBC. Okay, that is one possibility, or hemoglobin less than 11 grams. So this is a quantitative definition of the anemia, or both. So it could be the hemoglobin less than 11 gram percent, or decrease in the RBC count, or both. What is the grading? This is very important for us as far as treatment is concerned. There are other factors also. You will come to know about it when I talk about the management of anemia. WHO has graded it anything less than 11 is the starting point, that is anemia diagnosis, not 10. Somehow, when I was in Manipur, most of the students were telling 10 grams. Some textbook, a famous textbook had given it as 10 grams, and everybody was answering that, and they were getting into trouble. So please remember, it is not 10, it is 11, right? 11 grams and less is called anemia. In that, the simple WHO classification is mild is 8 to 11, moderate is 5 to 7, and severe is anything less than 5. So always WHO goes for a simple way of classifying things. So there are only three things: mild, moderate, and severe. Whereas ICMR has added one more grade there. Mild is anywhere between 10 to 10.9. They are more specific here. Moderate is 7 to 9.9, and severe is 4 to 6.9, and very severe is less than 4. This is very useful as far as treating the anemia is concerned. The Center for Disease Control, CDC, has trimester specific numbers. First trimester, anything less than 11. Second trimester, anything less than 10.5. Why they have gone zero point 0.5 less? Because of the physiological anemia that happens. What is it? I'm going to tell shortly. And in third trimester, it's back to 11. So that's very, very simple. So I think probably all of us should know about WHO as well as ICMR when you're taking exams in India. So how to classify? So classification, when you talk about this, it is divided into acquired as well as the congenital. Congenital in the sense the hereditary type of things. Acquired is deficiency is the main cause of anemia. The deficiency can be isolated, that is only iron deficiency, but it could be combined, but always it is combined. Most of the time it is combined iron protein deficiency or vitamin deficiencies. So it could be iron deficiency, folic acid deficiency, vitamin B12 deficiency, or protein deficiency. You will soon come to know the role of folic acid and vitamin B12 and protein in the formation of hemoglobin. So it's usually a combined deficiency. Hemorrhagic. Somebody has lost the blood. Obviously, there will be anemia. So it could be due to acute loss, PPH or APH, or it could be a chronic loss in terms of infestation by hookworm. That's the most notorious one, or infestations. And hemolytic, that is breaking of the RBCs, which could be acquired due to a disease like malaria, dengue. And bone marrow insufficiency. This could be aftermath of any radiotherapy or suppressive agents, drugs, and infection also. As I was telling, hereditary, it's not congenital, it's hereditary type of anemia. Hemolytic, familial hemolytic anemia. Hereditary spherocytosis is an example of that. RBC membrane defects, so where the RBCs will be broken easily. Hemoglobinopathies, these are, like sickle cell anemia, thalassemia, aplastic anemia, or hypoplastic anemia. I'm going to talk about each one of them in detail towards the end of the talk. Maybe I have to go as part 2 tomorrow. Iron in diet is very, very important for us because, as I said, the first cause is deficiency. If there is deficiency in anemia, see, you may be from the affluent country or a developed country, but if you're only eating burgers or French fries, there will be anemia. So you have to know what type of diet will contain iron. Heme iron is present in animal flesh or viscera like liver, red meat, chicken, fish, and eggs. Its absorption is easy, may increase the risk of cancer, stroke, heart diseases, and metabolic syndrome. Whereas absorption is not affected by any inhibitor in this type of heme iron. That is the advantage of that. The other one is non-heme iron, which is found mostly in vegetables, cereals, and beans, plant food basically. Absorption is not well absorbed, can be increased by enhancers and decreased by inhibitors. So the non-heme iron is the one which is affected by, suppose, for example, if you take along with vitamin C, the absorption is better. But if you take with phytates, it's not good. If you take with calcium, it's not good. That's exactly why we always say iron and calcium should not be given together. One of the companies long back, if I remember, they had put everything in one tablet, saying that it's the best tablet that is available. Then I challenged that, and then they, of course, they have changed the combination. Iron and calcium should not be given together. And we also tell the patients very clearly that iron should be taken at a different time and calcium should be taken out at a different time. Usually I tell them that iron can be taken in the afternoon. The calcium can be taken in the afternoon. It's a white tablet. Also, calcium will be well absorbed in the afternoon sun. Whereas the the iron tablet, which is red, can be taken in the night after food, or best, of course, always to be taken empty stomach, but nobody wants to take iron in the early morning, empty stomach. So that's why we advise like that. Enhancers and inhibitors of absorption are the enhancers, heme iron, protein, meat, ascorbic acid, ferrocin, gastric acid, alcohol. Of course, I don't advise alcohol to be taken along with iron tablets. Low iron stores are the enhancers. When the body is hungry for iron, it is absorbed better. Increased erythropoietic activity happening in the body, so it requires a lot of raw material. So iron is absorbed better there. Whereas the inhibitors, as I already said, phytates, calcium, tannins, tea, and coffee, any milk product for that matter. So don't take iron after taking tea, coffee. So maybe, as I said earlier, best is empty stomach, but empty stomach can be so irritating for many women. As it is, they don't want to take iron because it has got certain gastric side effects. It can cause constipation. It can make the stools dark colored. And generally, people do not want to take tablets. So better to, adjust all these things. Absorption and metabolism. Absorption is happening in the duodenum and proximal jejunum. That's exactly why now there are entry-coated iron tablets available, which are not actually broken in the stomach. They go down to duodenum and then they are opened and absorption is happening there. Only 10% of dietary iron is absorbed normally. Rest of requirement should be substituted by oral iron. Even when you give elemental iron, 10% of it is absorbed. That's exactly why you should know these calculations. All these questions are asked in the exam. So there's a dietary, the daily requirement, and based on that, based on the fact that only 10% is absorbed, you have to adjust the tablets accordingly. I'll come to that when I talk about the management. Metabolism is balanced by hepcidin, that is hormone from the liver, ferroprotein, uh, that is iron export protein, and erythropoietin. This is a very, very important enzyme. So hormone produced by kidneys 90% of the time. That's exactly why if there is any urinary tract infection, this erythropoietin is not secreted well, and that's a connection. So all these facts and knowledge is important when we take the investigations. So you may wonder why. I hope you remember when I talk about the investigations, this particular point. That is, whenever there's anemia, you have to ask for urine examination. What is the connection? The connection is here. Erythropoietin is produced by the kidneys, and erythropoietin is important for the production of hemoglobin. And liver, of course, 10%. Increase in pregnancy due to placental lactogen and progesterone. It increases the red cell volume by stimulating stem cells in the bone marrow. So erythropoietin does two jobs. One is it stimulates the stem cells in the bone marrow. And of course, it is increased in the pregnancy due to placental lactogen and progesterone. So this is how the absorption goes. As you can see here, the food iron is divided into heme iron and non-heme iron. So that will be absorbed here. That is a heme transporter. It's in the duodenum, cytochrome B, and it is lost by shedding the epithelial cells. It converts into mucosal ferritin, and ferritin is the one finally which is stored. And all these are helped by hepcidin from the liver and plasma transferrin. So this is the picture. If you can remember and write in the exam, you will get more marks. Physiological anemia. I promise you to talk about physiological anemia. This can be a short note for undergraduates. Also, sometimes for postgraduates, some universities have short notes. So physiological anemia is nothing but an anemia which is due to physiological changes that occur during pregnancy. All of us know there are lots of physiological changes occurring. Everything increases, right? The blood cells also increase, the plasma volume also increase, but they are not proportionately increasing. Blood cells increase, suppose, let's say, for 30 to 40%. The plasma volume increases by 40 to 50%. The reason for plasma volume increase is to make sure that the fluid is nicely circulated all over, including the uterus and the baby. So as a result, what happens? The available cells are diluted, isn't it? So that causes anemia. And this takes at least 20 weeks. So that's why physiological anemia is seen after 20 weeks. That's why if you remember, CDC has brought down by 0.5 in the second trimester. That's mid-trimester, mid-pregnancy. It is due to, as I said, hemodilution, number one. And number two is negative iron balance. The baby is a parasite, basically. It sucks the iron or hemoglobin and everything from the mother. At the cost of mother, it leaves. So that's why sometimes mother may be anemic, but baby may not be so anemic. Unless mother is severely anemic and chronically anemic, the baby does not suffer much. Hemoglobin is not less than 10 gram percent. This is how you differentiate between pathological anemia and physiological anemia. Now, this is another confusing number for you. The diagnosis of anemia is less than 11 only. It will not change. But if you want to differentiate, whenever it is less than 11, between pathological anemia and physiological anemia is somewhere between 10 to 11. It is less than 11, but it is never less than 10. Whereas pathological anemia can be 10 also, 9, 8, 7, anything, right? So if it is 10, the border point, how to know whether it is physiological anemia or it is pathological anemia? For that, we need to know the next point, that is PCV is not less than 30%, right? One more differentiating point is in physiological anemia, it is always normocytic, normochromic picture in the peripheral smear. Whereas in pathological anemia, it is microcytic and hypochromic picture. I hope I'm clear. When two ladies are having 10 gram hemoglobin, both are anemic. One is physiological, one is pathological. Physiological, it will be normocytic, normochromic anemia. Pathological, it will be microcytic, hypochromic anemia. So this is a very important slide. It will be asked in the exam. Now I come to iron deficiency anemia, which is the anemia which is commonly seen in India and elsewhere also. This is very, very important. So there are different stages of this iron deficiency anemia. As you can see here, when it is normal situation in a lady who is not anemic, the storage iron is full there, and transport iron is also, it is a totally filled area. Erythron iron is also full. So marrow iron is 2 to 3 plus. Serum ferritin is 150, very good. Saturation is 40%, excellent. HCT is 45 and RBC morphology is normal. So everything is normal here. So the 3 stages of anemia, depletion of iron stores happens first. Okay, that means it is not seen outside. Your store is being depleted. There is something still in the showroom. Okay, so whatever is there in the store is being brought to the showroom. So what happens, as you can see here, this is totally filled area, block. Here it is depleting, but the showroom doesn't show that she's anemic, right? So marrow is 0 to 1%. Serum ferritin is going down from 150 to 120. Saturation is 35, it's okay. This remains 45 and RBC morphology is also normal. It goes to the next stage of iron deficient erythropoiesis, right? So here, as you can see, the store is almost white. From dark brown, it has gone down to become white. And this was completely filled box. Now you can see there is some iron deficiency, and marrow iron has become 0 from 2 to 1 to 0. And now ferritin, look at this, it has gone below 100. Saturation is gone below 30. And HCT is also going down, whereas RBC morphology is still normal. The next stage is a frank deficiency anemia, where, as you can see, the store is white and the iron also is looking white. Showroom is also not showing much of iron there. And marrow iron is 0. Serum ferritin is less than 15. It should be. It's shown as 20 here. I have round up always, and for the rhyming word, ferritin 15. So whenever it goes down, it is anemia for sure. Saturation is also less than 20 and HCT is less than 40. Now you can see morphology as microcytic hypochromic picture, right? So that's a very important slide. Please take a screenshot if you are not taken, and this is very important. 3 stages of iron deficiency. Iron hemostasis, this you should know a little bit, how the iron overload will regulate or it will affect the homeostasis. So in iron deficiency, what happens? This is another picture that you have to write in the exams. As you can see here, hepatocytes are in plenty. When it is overloaded, hepatocytes are less. So then there will be hepcidin and other metabolisms that are happening here. You should, if you remember this picture, it's well and good. If you don't remember, don't worry about it. How iron is excreted in the body? 1 milligram of iron is excreted daily through various mechanisms. That's why we have to replace that, isn't it? Minimum. Sloughing of skin cells, we are not what we were. Every day we change. We don't realize that. Our skin changes, our gut mucosa changes, everything changes, right? Shedding of cells lining the gastrointestinal and urinary tract. That's what I just now told you. Iron from the old erythrocytes will be recycled and reabsorbed for formation of new RBCs. So body has a recycling mechanism. That's what we are promoting now, isn't it? Recycling. So now let us look at what are the causes of anemia. First, we'll talk about general causes, then the causes in pregnancy. Everything has to be written in a systematic way. The answer should be categorized. You should not simply write random answers like undergraduates. Postgraduates should always categorize the answer. That is appreciated well. So coming to causes in general, faulty diet. Anybody, whether it's a pregnant lady, non-pregnant lady, me, you, anybody, a faulty diet will give rise to anemia. That's what is meant by general. Rich in phosphate and phytic acid. So that we have to take care of that. Faulty absorption. It's always not just you may be eating correctly, but there is faulty absorption. That is because of infestations or hypochlorhydria. And loss. So there are three things, isn't it? One is the intake, absorption, and loss. And may be lost in the form of menorrhagia. Suppose she was having menorrhagia before becoming pregnant, definitely she would have anemia. Infestations during pregnancy also is a cause. And malaria, dengue, these are the ones which will destroy the RBCs, right? So this is a cause in general. Cause specific in pregnancy. There is increased and abnormal demand. Increased and abnormal demand. From whom? From the baby, from the mother itself. So mother has to cope up for herself. So there's an increased demand, and abnormal demand also from the baby. So as a result, there'll be total increase in the demand. Diminished intake and disturbed metabolism. In pregnancy as such, especially in the first trimester when they are having so much of nausea, vomiting, there will be diminished intake of food in general. And also the metabolism is disturbed because of the so much of hormonal changes that are happening in the body. As a result, there will be diminished intake as well as absorption. Pregnancy competes for folic acid, vitamin B12, and proteins. Who is competing in pregnancy? It's the baby. Baby wants folic acid, baby wants vitamin B12, baby wants proteins to build up its own cells. So there is an increased competition in pregnancy for the same, what do you call, the raw material to form the hemoglobin. So I was promising to tell you what's the connection between folic acid and proteins and all these things. And this is a very, very important slide. You must know this equation very nicely. So pyrimidine base in the presence of vitamin B12. So vitamin B12 is important. It's a raw material. It is converted into uracil. Now, uracil is the substrate for RNA. RNA is the one who writes the codes for all the cells, right? Okay. Now, folic acid, another vitamin which is required, is converted in the presence of vitamin C, one more vitamin, into folinic acid, right? Now, folinic acid and uracil, both of them are required in the presence of thymine, one more vitamin, for the formation of DNA. So DNA, RNA are finally the part of the cell, whether it is RBC or any other cell in the body. So to get there, you require all this support, right? Vitamin B12, thymine, folic acid, vitamin C, everybody. Of course, I'm not showing the protein here. Hemoglobin. Globin means who? Protein, isn't it? So it is very, very important. Erythropoiesis is confined to bone marrow in adult life. All of us know that. It is a continuous process. Every day there is formation, destruction happening. The raw materials, of course, minerals, iron and copper. Vitamins, we just saw C, folic acid, vitamin B12, and of course, protein for the globin moiety. And erythropoietin is required for the general erythropoiesis, which is secreted from the juxtaglomerular apparatus of the kidney. So all these things are required. Good. So we talked about the physiology of anemia. and how it happens, what is anemia, what are the grades, what's the physiology, what is the food contribution for anemia, and generally the causes, everything. Let us look at why we should bother to know about all these things. Obviously, it causes some effects on pregnancy. So effects during pregnancy. Again, as I told you, answer should be not just random listing. You should say during pregnancy, and in pregnancy, you can go for first trimester, second trimester, third trimester if you like, and then during labor and postpartum, right? So during pregnancy, these ladies having severe anemia can have abortions. Infections are always there. After all, you need good oxygen supply to fight the infections. So that's why if there's anemia, infections will thrive. Preterm labor, again, either because of infection itself or because of hypoxia. Either way, there will be breaking of the membranes and there will be release of the prostaglandins, hence preterm labor. Preeclampsia, there's a connection between preeclampsia and deficiencies of all the vitamins and all that we saw. So anemic patients will have preeclampsia. Cardiac failure, severe anemia, definitely heart has to work extra time to supply blood, to oxygenate the blood, and heart will give up. That's cardiac failure. During labor, after pregnancy, the problems continue. There'll be inertia of labor. Whenever there is no oxygen, any muscle fiber does not act well, so there will be uterine inertia. Prolonged labor, it is again the muscle fibers are tardy, they don't act well, so there will be prolonged labor. Postpartum hemorrhage, both because of postpartum hemorrhage, there will be anemia, and because of anemia, there is atonicity and there is postpartum hemorrhage. So it's like a vicious circle, cause and effect, both. PPH, if you dare talk about PPH or utter the word PPH, shock should be told in the same breath because they are a continuum. They are from the same spectrum. They are the same problem. Sepsis is the next problem, PSS. So it's PPH and PSS. Once you say PPH, there will be shock and sepsis. These are accompaniments of PPH. Cardiac failure, again, it can happen during labor because there is extra effort from the lady laboring. She's laboring. So extra work on the heart. So there will be cardiac failure. It is copy of the heart disease complicating pregnancy. There can be cardiac failure in the antenatal period, internatal period, and immediately after delivery because of the gushing of the blood from the periphery to the heart and loss of blood, everything together. Puerperium, again, sepsis is one of the important causes. And because of sepsis, there can be subinvolution of the uterus, failing of lactation, and venous thrombosis. These are all part of the same game, right? And because why venous thrombosis? There are four reasons for that. Number one is increased concentration of factor VIII. Once I asked this question in the class and no student could answer this. So I wanted them to find out, but today I'm giving it easily to you because I can't ask you to come back and tell me. So number one is increased concentration of factor VIII, compensatory thrombocytosis. Whenever there is anemia, there will be a compensatory thrombocytosis and change in rheology. Now, all students wanted me to tell what is rheology. What is rheology? Rheology is the way the RBCs move, right? When there is anemia and there's so much of clogging, the movement of the RBCs is not smooth and they will block these small vessels and that itself will give rise to less oxygenation of the tissues. So because of all this, the block especially, there will be venous thrombosis. Pulmonary embolism, these thrombi can just get dislodged and go into the lungs and there will be pulmonary embolism. So whether it is pregnancy, whether it's labor, whether it's puerperium, all the way there is problem in anemia. What's the effect on fetus? I told you actually earlier that the fetus is a parasite. It will live at the cost of mother. If the mother is anemic, it doesn't care, but it should care. If the mother is having chronic and severe anemia, there can be FGR or low birth weight at least. Prematurity because of preterm labor, very simple. IUD, again, IUD happens in a very long-standing chronic anemia with FGR. There can be IUD also. Asphyxia, definitely because the baby, mother, both will have severe shortage of oxygen, neonatal and infant anemia. It will be carried on to the baby. and increased perinatal mortality because of all the above. So, when we know so much about anemia, we need to know how to take care of a patient having anemia complicating pregnancy. So the central aim of antenatal care. Now, this particular slide is common for all medical disorders in pregnancy. In fact, I should have taken this class first. In undergraduate, we take this class first. And then comes the cardiac disease, then the preeclampsia, then diabetes, and all the other medical problems. Because this class or this topic sets the tone. It's same for all topics in medical disorders of pregnancy. The central aim is prevention of certain problems. Here it is prevention of cardiac failure. In cardiac disease, again, prevention of cardiac failure. In preeclampsia, prevention of eclampsia. In diabetes, prevention of ketoacidosis in mother and macrosomia in the baby. So like this, the central aim of any medical disorder is prevention of a complication, which is related to the original disease. And the original disease here is anemia, and the central aim is prevention of cardiac failure. So when you have to prevent certain things, you have to do more frequent or close monitoring and screening for the problem. The screening is nothing but look for it. Look for anemia. That's exactly why hemoglobin estimation, in fact, 4 times in pregnancy, has become what is called routine investigation. It has to be done, otherwise you will miss it. Look for it. More frequent antenatal checkups. Of course, other day I was during talk on high risk pregnancy, I was telling minimum or the ideal antenatal checkup is 15. That is once in a month up to 7 months, once in 2 weeks till 36 weeks. That is another 4, and then every week in the last month. That is another 4. Total 15. Whereas when you see a patient of anemia, right from the beginning, it could be once in 2 weeks, right? Regular checkups with the cardiologist. Of course, there is always confusion between a case of severe anemia and a heart disease, because in a case of severe anemia, there can be a murmur in the heart. But how do you differentiate? I told you this in the cardiac case discussion. The main difference is in cardiac disease, there will be diastolic murmur, whereas in anemia, there won't be diastolic murmur. Yes, how to differentiate in the systolic murmur? In anemia, it is short, soft murmur, okay? Whereas in case of cardiac disease, it is a long and pansystolic murmur with a thrill. So that's how you differentiate. Short murmur, the length of the murmur is short. It's almost at the time of systolic maybe. And it is soft. It's not very harsh or hard. And you won't feel any thrills. That's how you differentiate. Look for complications like cardiac failure and any other complications. Look for signs of failure. Okay, complications could be infection as well. Signs of failure, edema, generalized edema, and crepitations. Timely admission for iron or PRBC. Nowadays, we don't give blood, we give blood products. PRBC is better than just giving whole blood. Because whole blood, if you give, there will be a lot of plasma there, and that will increase the heart load, isn't it? What are the symptoms? Symptoms, of course, depend upon the degree of anemia. Weakness is one of the leading symptoms, fatigue and giddiness. These are the initial symptoms. A smart obstetrician and a smart person doctor will recognize this as an early sign of anemia. When the patient has got anorexia and pica, of course, it is already gone into moderate to severe. Pica is, patient desiring to eat anything and everything. Lord Krishna was eating mud. Pica, maybe he was anemic. We don't know. Nausea, vomiting, and diarrhea. So that is the next stage when anemia is becoming severe. Palpitations, ectopic beats, and angina. Very severe anemia, almost near the cardiac failure. Dyspnea and swelling of the legs. She's almost in failure. These are the pictures given in any textbook. Paler in the conjunctiva and paler on the nail beds. Chylonychia, platynachia is not seen that commonly in pregnancy. And the tongue is dry, and there will be, if vitamin B12, B complex deficiency is there, there will be angular stomatitis as well. The signs are very important. It depends again on degree of anemia, of course. Pallor, koilinikia, as I said, koilinikia is not seen in pregnancy as such. It requires a long-standing chronic anemia. Pallor, of course, yes. Glossitis, I told you, and angular stomatitis in accompanied vitamin B complex deficiency, brittle hair, and edema, and soft, short ejection systolic murmur. As I told you, it happens during the systolic period. It's called ejection systolic murmur, soft and short. Basal crepitations means she has already gone into cardiac failure. So let us look at the management now. Again, this slide is common for all medical disorders in pregnancy. Management includes management of the disease. Today's topic is anemia, so management of anemia. In case of diabetes, management of diabetes. In case of preeclampsia, management of hypertension. And in case of any other disease, thyroid disease, management of thyroid problem. Second, prevention or treating the complication, right? So after managing the disease, we should simultaneously make sure that complications are prevented. And what's the complication here? Cardiac failure. And third is obstetric management, which is common for all patients, whether it is diabetes, preeclampsia, anemia. So let us look at in these three headings. First of all, management of anemia. And first slide will be investigation. This is a very important slide and a very important question for undergraduates as well as postgraduates. Again, don't simply list the investigations randomly. You have to categorize the answer and answer accordingly. What do you mean by categorization? First category is to note the degree or grade of anemia. What investigations to be done? Hemoglobin. To know the degree and grade also, right? We have seen the different grades. In the first slide, WHO grades are different. ICMR grades are different. 4 times in a pregnancy, maybe first in the first visit, second in the second trimester, and twice in the third trimester. PCV, RBC count. These all will talk about the grade and degree of anemia. The second category is to note the type of anemia, whether it is microcytic hypochromic, macrocytic hypochromic. That will be told by peripheral smear. Also, you can make out by indices like MCHC, which will be less than 30%, MCV, that is mean corpuscular volume, which will be less than 80 cubic millimeters, and MCH, which is less than 25 picograms. Serum iron also will tell you about the type of anemia. If there is iron deficiency, serum iron will be low always. SIBC, serum iron binding capacity, will be more if there is anemia due to iron deficiency. Serum ferritin will talk about the storage, right? So serum ferritin will be low in case of iron deficiency anemia. So these investigations are to note the type of anemia. The next one is how to grade it. I'm again repeating for the easy remembrance. WHO, mild is 8 to 11, moderate is 5 to 7, severe is less than 5. ICMR, mild is 10 to 10.9, moderate is 7 to 9.9, severe is 4 to 6.9, and very severe is less than 4. CDC, it is trimester specific, 11 in the first and third trimester, 10.5 in the second trimester. I'll continue with the investigations. The next category is to note the cause of anemia. To note the cause, urine examination. Now, you remember what's the connection between urine examination and anemia? It's erythropoietin factor, which is secreted by juxtaglomerular apparatus of kidney. If there's kidney infection, urinary tract infection, there can be anemia. That's why urine examination is important. Unless you treat this, no amount of iron is going to help. That's why it's called refractory anemia. Refractory anemia means one which is not responding to the iron. Why it is not responding? Because there is no erythropoietin factor. You have not treated urinary tract infection. Examination of the stool for what? Hookworms, right? Ova and cysts. Unless you treat that, whatever you go, it will go down the drain. Hookworms will suck out everything. Fractional test meal to know whether there's enough hydrochloric acid or not. Otherwise, iron will not be absorbed properly. Serum protein, of course, hemoglobin means heme and globin. If there's protein deficiency, there will be anemia. Osmotic fragility tests to know whether there's hereditary spherocytosis, breaking of the RBCs. Electrophoresis will tell you about all hereditary anemias like thalassemia, sickle cell anemia, and all that. This is usually done in the end. I put a question mark on bone marrow because bone marrow is not done as a routine. It is done when all other tests have shown nothing much, and maybe she is a case of, blood cancer or leukemia or any other type of suppression. So we have to do a bone marrow testing. What are the blood values in IDA? Here I have rounded up most of the values for easy remembrance. Hemoglobin in a non-pregnant level is 14, and in iron deficiency anemia is less than 11. This I have told many, many times. Don't forget 11. PCV less than 30 or 30% only in iron deficiency. Serum iron is less than 60. It's actually 70, but I have rounded it up. I just told you, and make it easy to remember. 30, 60, 15 is easy to remember, isn't it? TIBC is 300. So I'm going with the table of, let's say, 30. 30 double is 60, and 10 times is 300. That means iron binding capacity is increased. Ferritin is 15, actually 20, but 15 why I'm saying is because ferritin, 15, it rhymes. So easy to remember, right? Also, it's half of 30. I'm going with 30, isn't it? Saturation, less than 15% again. And peripheral smear shows microcytic hypochromic. So please remember these numbers. It's very, very important. PCV 30, serum iron 60, TIBC 300, ferritin 15, saturation less than 15. So these are the values. Coming to peripheral smear of iron deficiency anemia, as I said, it will be hypochromic, microcytic. I think the picture is missing. So I'm sorry for that. And you can see the picture anywhere else. Prophylaxis. Now, why we should give prophylaxis? As I told you earlier, we lose iron during pregnancy. For fetus in placenta alone, we lose 300 milligrams in the pregnancy. For maternal hemoglobin expansion, 500 milligrams is required. And that is shed through the gut to replace them. And urine and skin, 200 milligrams. So altogether, there's an extra requirement of 1,000 milligrams in pregnancy. This is a sure short question in the exam, either MCQ or Viva or anywhere. So total extra requirement is 1,000 milligrams throughout the pregnancy. Now, how to make that up? So you have to divide it by the 280 days that you have, right? So in other words, 40 weeks, 40 weeks into 7 days. So when you do that, you will get what is the daily requirement. So average requirement is 4 to 6 milligrams per day. Let us take it as 6 milligrams per day. It can be 4 because it's say 280 into, let's say per day into 4, it becomes almost like 1,000, but 6 milligram is always better. So to get the 6 milligrams, you have to give 10 times because, only 10% is absorbed. 60 milligrams of elemental iron is required. If you take 60 milligrams of elemental iron, 10% is absorbed. So you'll get 6 milligrams per day. In early pregnancy, the requirement is little less, maybe 2.5 milligrams per day. At around 20 to 32 weeks, it shoots up to 6. So that's why we can keep it at 6. 32 weeks onwards, it goes up to 6 to 8. So that's why I'm averaging it to 6 during pregnancy. Postnatal iron requirement, 25 milligrams per day because she would have lost so much of blood during postpartum hemorrhage. She's lactating the baby, so she requires more. So how to do prophylaxis? Why we understood how to do prophylaxis? Avoidance of frequent childbirth. That is one of the best things that you can do. A minimum gap of 2 years after the delivery, before she becomes pregnant, not delivery to delivery. Deworming with tablet albendazole 400 milligrams once in a way is always good, especially in the infested areas. Supplementary iron 60 milligrams per day. I told you already this many times, so I'll repeat one more time. 60 milligrams daily, only 10% is absorbed, 6 milligrams. In the previous slide, we saw clearly 6 milligrams is the requirement per day. Folic acid, 0.5 milligrams daily, which is required for the formation of heme. Vitamin C, 500 milligrams. Again, you saw it in the nucleic acid metabolism. Iron-rich food, green leafy vegetables, red meat, dates, egg, citrus fruits can prevent iron deficiency anemia. Citrus fruit will give you a lot of vitamin C. Vegetables also will give you non-heme iron, which is better. And administer in empty stomach. This is what I've been telling. Best time to take any tablet is empty stomach, but people won't take it. Do not give calcium simultaneously. I've told it again. I've told you the story also. So don't give calcium and iron together. What is this Anemia Mukt Bharat? I think there I will stop today's class. Government of India has vowed itself to have Anemia Mukt Bharat. This is a better slogan for all of us. 6 beneficiaries, who are they? Children, 6 to 59. Children, 5 to 10, 59 months there, which is missing. Then children, 5 to 10 years. Adolescents, 10 to 19 years. Women of reproductive age group, pregnant women, and lactating women. So all except maybe adult men, right? These are the beneficiaries. What are the 6 interventions that you have to do? Prophylactic iron and folic acid supplementation, deworming, behavioral change and communication, testing of anemia using digital methods and point of care treatment, iron and folic acid fortified food, and addressing non-nutritional causes of anemia, right? Then 6 institutional mechanisms: intra-ministerial coordination, National Anemia Mukt Bharat Unit, National Center for Excellence in Advanced Research and Anemia Control, convergence with other ministries, strengthening supply chain and logistics, dashboard and digital portal. 6 into 6 into 6. 666 is in the Omen movie, if you have seen, 666 is bad, but 666 is very, 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 very good as far as Anemia Mukt Bharat is concerned. So how to give that? Prophylactic iron folic acid supplementation regime, age group, women of reproductive age group, non-pregnant, non-lactating, anybody, 20 to 49 years. Weekly 1 iron and folic acid tablet. 1 per week is not asking for much. Why? Every month they menstruate, right? So they lose. Each tablet contains 60 milligrams of elemental iron. I've already told you 60 milligram is minimum that is required because 10% is absorbed, 6 milligrams is required. 500 micrograms of folic acid, sugar-coated red color. All women in the reproductive age group in the preconception period and up to the first trimester of the pregnancy are advised to have 500 micrograms of folic acid tablets daily. Now, this is non-pregnant, non-lactating. Action points for severe delivery to pregnant and lactating. So once they become pregnant women should be provided 180 sugar-coated red iron and folic acid tablet, which contains again 60 milligrams of elemental iron, 500 micrograms of folic acid from second trimester onwards throughout pregnancy. 180 days. 180 days. See, first trimester is almost, let's say, 13 weeks. 13 weeks into 7 is almost 90 days is gone. And remaining is 180 days in the 280 days thing. So throughout second trimester and third trimester, you must give tablets. That's why they are giving 180 tablets. Earlier, we used to say 100 tablets, but now it is corrected as 180 tablets. Now, you may be seeing here, first trimester, they are not giving. Is it contraindicated? No, it's not contraindicated in first trimester. The only thing is patients cannot tolerate. And as you saw in one of the slides earlier, the requirement in the first trimester is just 2.5 milligrams. It's not so much, correct? So that's why we are not giving in the first trimester. We are giving second trimester onwards when the demand increases. Physiological anemia starts in the second trimester. So that's why it is. Whereas folic acid is given even in the first trimester, which you saw in the previous slide, right? Services to be provided through antenatal care contacts, ANC clinics, VHND, and PMSME. Receipt of IFA and folic acid tablet screening and point of care treatment of anemia and screening and prevention of malaria should be rigorously synced in implementation. 180 sugar-coated red folic acid tablets to be continued postpartum 180 days. 6 months before delivery, 6 months after delivery, simple. 1 year they have to take. It's 180, not 100. Before delivery, 180 days. After delivery, 180 days. No scope for any confusion. Throughout the pregnancy, even after delivery, 180 days. I think I will stop there today's class. I'll have to continue tomorrow. Thank you so much.